humihinga sila or they put pressure on the stomach, may napoprotrude na tissue at the front, on the side of the abdominal area, that's not a good sign. Patients who have ostomies, ostomies on the stomach, on the bowel, urine, whatever ostomy, it's going to be a problem because you will not be able to generate enough pressure if you have a compromised fascial system. That's already been proven, been said. So if you have a patient that has herniations, there's only so much that we can do to help them because structurally they already have a problem. So in order for us to treat them, it may come to a point that may have to be addressed by the doctor. Not everything can be treated by PT. We have to respect the fact there are certain limitations of what we can do, and one of which is if you have a compromised fascial system, you cannot generate enough intra-abdominal pressure because of the injury of the fascial system, then it's harder for anyone to be able to generate enough pressure to support the back. Ergo, we cannot have less pain. Okay? Next slide. So this is just a cross-sectional diagram of your back, and you'll see your transversus abdominis being the innermost layer on this diagram. Alright? And we say that the transversus abdominis has the ability to tension the thoracolumbar fascia, which in turn helps support the back. Alright? Okay. So next slide are just your dermatomes. Respect the fact that we all have different kinds of dermatomes. Yours is different from mine, but it's going to be there. Your back is capable of referring pain down to your leg, and we have to respect the fact that each of us have different presentations of dermatomes. So on the next slide are just references that I've placed there. There are a couple more. Are there any more? No, not that I know. Alright, so those are good references to look at. Next one, biomechanics of the lower back. So, on slide number 35, you have different mechanics of movements on your back, front, back, sides, up and down. Alright? Like what we said on the next slide, if you do eggshell compression, your discs are gonna get bigger. So, if the patient is standing and you provide manual compression on the spine by pressing down on the shoulders, if they complain of pain, it can be because of stenosis, it can be because of IV disc problems or degeneration. And if you lift them up or deload the back and they have less pain, then it may verify your findings. Now, sometimes it's not a problem of anatomy, but it's a problem of mechanics, meaning you don't always have to identify which structure is involved. With McKenzie-based treatments, they only are concerned about which direction will make the most for the patient that they will have less pain. They don't care whether it's your joint, your muscle, your nerve that's irritated. It's important to find the direction of preference. That's the biggest thing, is to find the direction. And I think there's a lot of wisdom behind that, because in manual therapy, we tend to be more patho-anatomical in nature, meaning we look for the anatomic structure that's a problem, but sometimes that limits in terms of validity, because it's not always the case. Hindi naman palagi yung anatomy problem. Sometimes it's just a mechanical movement. You just have to look for the direction of movement that makes the patient better. Alright, so slide number 37, like what we said, eggshell distraction. Now, in terms of flexion, so there is a forward movement of the vertebral body and an anterior rotation of the vertebral body when you flex. Alright? And what happens, like we said, it opens up the intervertebral foramen. So if you look at the next slide, number 39, you will see that you have an opening of that intervertebral foramen, opening of the facet joints. Number 40 is extension. So when you extend, you compress your spine, you compress the intervertebral foramen, you compress the intervertebral and the facet joints or the Z joints. Alright? And sometimes the spinous processes get compressed. It's the one that stops the movement. Alright? Okay, number 41 is just another diagram of that. That's from I can't remember. Anyway, it's been a long time. So the next slide will be rotation. So in rotation, you will see that your intervertebral foramen also plays a part in stopping you from moving further into the range. And let's say if you turn towards the left, you'll see that the right intervertebral foramen is being compressed. So when we turn to the left intervertebral foramen or your facet joints instead opens up, your right side closes down. Alright? So again, when we flex, facet joints open, intervertebral foramen opens. When we extend, intervertebral foramen closes down, facet joints closes down. When we side bend to the left, alright, ipsilaterally, the facet joints close down, contralaterally, the facet joints open up. When we turn, alright, to the left, the facet joints ipsilaterally opens up. The facet joints on the contralateral side closes down. You got that?
Yes.
Yes. You want me to repeat that again?
No, sir.
It's okay.
Okay na po.
Okay, sige. 43 is just the same as what we said. So we go now to anatomy of this. Right?
Wow, 8 minutes. Almost 9 minutes.
No, sir.
So, anatomy of the sacrum na tayo.
Yes, sir.
So, slide number 46. So, different parts are there. Your median sacral crest. You've got your lateral sacral crest. These are just ridges around your sacrum. So, they are all 5 parts. And you also have the coccyx. Ulo ka, pwede ma-fracture or ma-dislocate ang coccyx. Okay? Next. Yan. Articulating process, which is on your first part of your sacrum, and then a sacral promontory, which is at the front part. Okay, so if you look at the next slide, this is sort of Diane is a very well-known PT from Canada. So if you look at the slide on number 48, you'll see that you have articulating surfaces on your sacrum. Short arm, which is vertical position, articulating surface, and a long arm, which is horizontally positioned. slide would be you have several sacrum, you see different kinds of sacrum, and each one with different, presentations. Not everyone has the same kind of sacrum. So at different angles, and if you look at the leftmost or rightmost picture, magkaiba yung orientation compared to the left. They're not the same. Now, why can this happen? Can you give an idea?
Any idea daw po?
Kung bakit iba-iba.
Why this happens?
Bakit daw po kaya medyo iba yung sacrum dito sa left and sa right?
Yung function, di ba sa male and female?
Sir, sabi ko yun na gender daw po.
Pwede? What else?
What else daw po? Muscles daw po, sir.
Yep. Pwede rin. Ano pa? If you think about it, when we were young and we were still a child, still a baby, bata pa ako rin ako nang umabot din ako. But nung bata tayo, we don't have a definite structure. Everything is cartilaginous in nature. All of us develop differently. Meaning, some of us were able to walk fast, some of us were delayed, some of us cannot turn to the right, some of us can turn only to the left. There are several factors that can lead to the asymmetry of the sacrum. So I think this is a more important thing to remember, that we were not born and designed with a good musculoskeletal system. It was, part of it is genetic, obviously, but some controllable factors is that the way that we develop when we were a child is important, because as we grow, that's where muscle starts pulling and putting pressure on the cartilages, on the bones of the different segments of our body, and that's when they start to remodel themselves. So the remodeling phase of these bones depends on how good developmental was when we were young, developmental milestones. Now, how can that be? If you have an amputated foot, obviously you're going to have problems with your back in years to come. You're going to have probably scoliosis just because your foot was amputated. See that a lot. So you have to respect the fact that what happened when you were young can also affect what happens to you now and as you age. So that's why this can happen. Okay? Alright. There's so much more topics that we can discuss on the back. Unfortunately, it's a very big topic, and maybe when I get home, I can share what I know and how much it has changed in the past decade. It really has. I mean, I'm telling you, it's what we know now has been what's been discovered 10, 15 years ago. So those transversus abdominis, the ultrasound, those have been there since 10, 15 years ago. And right now, it's changing again. So let's go to number. You're enough.
Sir, wait lang po.
Hmm?
Wait lang po, sir. Okay na po.
I-51 would be your nominate. So you've got a combination of ischium, ilium, pubic, right? With your innominate bone. Now, there are certain landmarks here that are important that you should know so that when you do manual palpation, it's easier. So more commonly, you have your iliac crest. The level of the iliac crest will be your L4, L5, generally. So when you place your